present today some things that have been going on behind the scenes for me in the last 6 to 12 weeks, and really looking at this post-COVID long haul clinic in which David Rosenberg, a member of the Pulmonary Critical Care Division, who was at one time the occupational health and safety for the system, is proposed because he had requests from the PCP crowd out there in Ahuja. Disclosures are not relevant, but they are listed there. And just want to remind people that this COVID-19 in Cuyahoga County, just in our own area, is big. There are new cases, about 5,600 was in January 2nd, and the 7-day average was pretty high, and that goes back to the 17th. So the NIH has identified the long COVID, or at least the COVID illness, as comprised of a early acute peak or acute phase, which goes for some period of time. And then in some group of people, a lingering illness, and then in others, a recrudescence, maybe, although it's not been defined, but at least it comes to clinical awareness because of patients and physicians in domains of fever, fogginess in the head, lung trouble, joint trouble, and heart trouble. Now, these are what a group of experts sitting around the table wearing N95 masks start to think about. And we'll sort of try to say, well, what is it more like on the ground? So this is the NIH Recover Focus, and it's about 1 out of 3 with an illness that's acute at 3 months have symptoms, and then there are a bunch of people that persist in their symptoms. So the objectives are: consider a prototypic patient that comes to the long haul clinic out of Ahuja, list the variations in the major complaints, recognize fatigue, depression, insomnia, and post-traumatic stress disorder as a sickness response from the animal world. There are animal models for this, and how to optimize individualized therapy through research. So this is the call for it. It's too busy here, but it's just the call for it was in October. There was some behind the scenes work on it, and it says dedicated to the comprehensive evaluation, diagnosis, and multidisciplinary treatment of patients with post-acute sequela of SARS-CoV-2 infection, more commonly referred to as COVID long haul syndrome. And there is a number, and you can be evaluated, and these are the symptoms that are listed. And this falls into a category of consultative medicine, and ironically, a recent article in the New England Journal of Medicine defines what a consultative medicine clinic is, which is a place in which you refer patients in which the diagnosis is mystified, right? It's you're mystified by it, and it takes a multidisciplinary group to be able to identify these. There are apparently 35 around the world, and they have a whole array of the medical school or the biomedical system team, as well as behavioral team behind them. So, going backwards. So here's a 52-year-old female. This is almost the average of all the first 40 that I entered. 52-year-old female, BMI 31, 10 months post-COVID, had fatigue as the primary complaint. Now, remember, they were asking for people with fatigue, so it's going to be enriched for fatigue, but had coexisting anxiety, cough, arthralgias, poor sleep, palpitations, dysphagia, and the fatigue severity scale was 60 out of 63. That's a 9-point scale. And we'll use the FSS as the major fatigue scale. There are others, but it's the 9-item, which is pretty common, probably be used across a lot of platforms. There was no report of brain fog. Now, I don't know. It's sort of like asking, do you have cataplexy? I don't know what the answer is to that particular answer. Do you have brain fog? I mean, I know I have brain fog every now and then, but that doesn't mean much. Sleep metric. Now, we had used two different kind of sleep health metrics. I normalized them to 100%, and it was about 58 out of 100. Then the MoCA for depression was 27, which is okay. I mean, it's there, it's depressed, PHQ-9, depression scale, anxiety scale, and ECOG scale. And we'll go and talk about that a little bit more. But as you can see, there are sort of 4 out of the 5 domains. No fevers were reported, no fever was present. Medications, had medications that produce fatigue, had a flat affect that was noted on physical examination. But you can see that this is a kind of a typical case. And the outcome of the consultation was a behavioral health services for anxiety, depression, and fatigue. Chest pain, dyspnea on exertion, CT high resolution, PFTs, ABG, 6-minute walk. HST for snoring and fatigue, insomnia and palpitations. Snoring was not a prominent symptom when they came in. And rheumatologic evaluation because of the history of arthralgias. And the clinic is to manage testing and refer. The outcomes of these referrals is pending, and they return to clinic in about 6 months. Now, this is sort of what it's evolved to be. And they've, so we're going to talk about the first 40 referrals. And I don't have outcomes on these yet, but this is the presenting symptoms. This age is about 53, BMI 31, 10 months post-COVID. Presenting symptoms, the primary or co-primary of fatigue is in 75%. Probably not, not unusual because of what the brain fog was present in 17 of the 40 people, 42%. Any sleep problem, 32, cardiopulmonary symptoms in 12, depression, anxiety in terms of their presenting symptoms. That is that they are depressed or they're anxious or they're reported that is 10. Taste and smell was a little bit there and cognitive decline. So if we have the questionnaire results, the Likert fatigue scale is a 10 centimeter, 100 millimeter scale, about halfway through, 4.9. Minimum was none, and maximum was maximal fatigue. The average of the 9-item FSS is 5.1, and it's usually about 2.5 for healthy populations. So it's about twice that. And for comparison, multiple sclerosis is about 4.8. Fatigue severity score, which is the 63 is the maximal. That's the each of the items scored to 7 was 45, and greater than 36 is severe fatigue. Depression, 5 to 15 is mild to moderate. GAD, anxiety, greater than 10 is thought to be pretty anxious. A MoCA depression score, lower is worse, and it's there. And then ECOG is a performance scale. So a 3 in the ECOG is you can't get out of bed. So 1.73 is somewhere between I get up and get around, but I'm impaired by my general performance during the day, and sleep is about 46 on a scale of 100. And we have no data yet or what the normal range is here. And I think we're probably going to end up using the PROMIS sleep questionnaire because it seems to be what people are using. We may use others as well.
Kingman, quick question
Yeah.
for you. Just if you go back to the little notes you have on the N for the PHQ-9 and the GAD,
Yeah.
say 27% greater than 14. Are you saying 27% had a score greater than 14?
Yep.
Okay.
Yep. 27% had, 30% had greater than 12.
Okay.
So that you can see that even though they may not report symptomatically, that their particular, if they report their questionnaire over recent times, they have a number of these people have a score on these questionnaires, the way they're asked and how they're perceived, have a little more load than one might expect from their presentation. So what are the correlates of fatigue? Well, fatigue reported in 75%, not reported in 25%. Brain fog was almost equally distributed. So the reported brain fog is not doesn't track with fatigue. Insomnia, yeah, probably fatigue and insomnia, they kind of go. I understand that. Dizziness, okay, maybe. I don't know what dizziness really means. Any sleep problem, about the same. Headache, a little less in the fatigue people. Dyspnea was a little less, but not, didn't, I think these are small numbers. Cough, smell. Anxiety was about the same. Psych comorbidity was about the same, but really it was interesting. Any history, when I went through the previous, what other diagnoses did they have before their COVID for any autoimmunes, Sjogren's, rheumatoid arthritis. I put a broad net out there for an autoimmune illness of some sort, psoriasis, things of that sort. I was really struck. It was really fatigue in those reported, and those that did not have fatigue didn't have it, and hypothyroidism. And then I looked into hypothyroidism and I said, well, adult hypothyroidism, what produces adult hypothyroidism? And 96% is thought to be autoimmune. So if you throw hypothyroidism and autoimmune disease together, it was a 50% of the people versus none with no report of fatigue. So that was the first sort of general surprise that perhaps a person who has a tendency towards an autoimmune, what we claim is an autoimmune response, that maybe there's something there.
Kingman, did they try to, was there any way, attempt to try to just assess the symptom of sleepiness directly?
Yeah, we had some sleepiness stuff. It didn't relate. Any sleep problem,
Okay.
33 versus 30.
Okay.
I
So
mean, we've been going, when I show this to people, the click murmur of sleep medicine rears its ugly head with UARS, right? Well, they're fatigued because they have UARS. And you go, okay, that's all right. All these things that you can think about, but you're sitting in front of one patient, and then you're sitting in front of 40, and that's only in the first month. And if it's 30, well, we'll go. So it's and we can dig into this sleepiness. I really don't like the Epworth sleepiness scale, but
yeah, no, I'm not saying that necessarily,
right.
but yeah, just curious.
So I was curious. I was going through some things, and one of the ways I like showing this is that the FSS has 9 different categories, of which 3 through 9 is thought to be the core questions. And they're rated from 1 to 7, each of these that the person goes through. And they're listed on the left: motivation, exercise. And here's a person who has a FSS score of 46. And you can see that, it's a pretty well-rounded fatigue person, right? They kind of have this sort of, and that's a way of kind of visually showing the distribution of scores with these different domains of fatigue that people use in this fatigue severity scale. I sort of like the way this is because it kind of gives you at a glance of, so the farther you're out, the more you're impaired in that particular dimension. So 1 would be motivation is really impaired. 2 is exercise effect is at a 5 out of a 7, and so forth. So you see these different things, and it's an individualized plot at that time. And we use it in our you've seen it in our literature where people talk about symptom presentation and the different symptoms that people have in sleep apnea when they present. Sleepiness versus other domains. So there are different flavors of fatigue. Here are high fatigue on the top, which you just saw, and or similar to a different patient, and then a medium fatigue here. You can see that there are various patterns to that. And I really want you to get a general sense of how one might flash up a kind of once you get a questionnaire in there, you can have an individual, and you can have a dashboard for this individual and see how they change. And this is an interesting one. There was little relation of fatigue to sleep or to brain fog. And sleep was this, how well do you sleep? It included sleepiness and other things. And on the left is brain fog absent, 3 examples in patients, and 33, 5, and 1. And sleep was 58, 36, and 43. So sleep is higher is better. And you can see that there's really, on the right then, is brain fog is present. Sleep was pretty good. And so sleep was pretty good, but brain fog was really was there. Sleep at 43 and sleep at 33. So that's poor sleep, and with brain fog, without brain fog. So there wasn't really any relationship to brain fog and sleep. And this is another way of showing it, with the brain fog being present as a red bar on top of whatever the sum of the FSS was on the left. And the right is brain fog by sleep, 100 being great sleep. And there's really no relationship. So I don't understand this brain fog. I know it's present in our patient population in narcolepsy, but I'm not sure I understand what that report is. I don't know if it's terribly important, but in the narcoleptic patients, it's clearly one of their primary concerns, and that it's not touched very much by the stimulants. So how does this relate to other recent reports? And there are not a lot of reports of this post-discharge symptoms. Now, here's one that is only 4 to 8 weeks post-hospitalization. They had people from the MICU and managed on the wards. It's a multidisciplinary team. They use specialist telephone screening, capture symptoms impact. So I thought it was an interesting follow-up way of doing that. Has some questions you can ask on the telephone. And the new illness that was related to fatigue, and new was really not defined very well, because it didn't really look at antecedent fatigue, but it was 72% from the people in the MICU and 60% from the ward. Breathlessness was 65% in the MICU and 42% from the ward, and psychological distress. So it's enriched with the MICU experience and illness that requires MICU. This is, though, an interesting metabolomic study, 60 days, post-acute COVID-19 infection in asymptomatic or moderately infected individuals. And many of these, this is metabolomics of the plasma. So, if you're a metabolomics person, you just call up some people and ask if you can get some blood and run it and say, aha, this is it. Well, what they show here is there are some mitochondrial proteins. It's not important what it is, but there are differences between those that have symptoms and those that don't. And they find a bunch of, mitochondrial stuff is starting to come up. And so that's one of the interesting mitochondria fatigue mitochondria kind of paradigms. And that's one of the things that's in the literature that and so you're really stuck with me looking over this literature and getting curious about certain things. And then I just wanted to also put the New Yorker article on long COVID in November of this year. Deanna Barrett is called the Survivor Corps in COVID-19, and wants to remind us that there's a patient perspective and that there's no such thing as mild case of COVID. Let me explain what they mean by mild, and what they mean by that is doctors say it's mild. They mean encephalitis. They mean COVID pneumonia. They mean end-stage organ failure, right? So it's just a scratch. Other quotes, the number one thing that kept people from going back to work was a drastic personality change. That's not reflected in any particular questionnaire that we ask about. There's a sense that they have somatic hypervigilance. Now that's seen in insomnia. It's also, I think, a feature here of this anxiety. But mental illness is still illness, and in their own way, the doctors are setting the rules about what kind of suffering counts. Now, the reason I put that up there is that there is a large group of long COVID survivors that have symptoms that are come from AIDS activists that are starting to sit there and push the NIH. And this particular person was one of the big proponents for this Recover program that Francis Collins put out pretty quickly in response to kind of the patient requests that this be looked at in an organized fashion. So interim summary, it's a defining illness of this decade, and the post-COVID is the secondary defining illness, whatever that is. There's a post-COVID persistence of illness, and maybe about 70% from the MICU, 60% from just hospitalized, and 30% of those not hospitalized. And when you realize that those that are not hospitalized are probably about 85% of the illnesses, this is huge. There's a persistence of inflammatory markers for about 60 days, and in some dramatic persistence of virus, especially in those immunosuppressed. How often that happens and where it is and how it is, I'm sure people are looking at that, but I don't know of anybody at Case that's trying to culture the virus out of all sorts of things. Management is a mess. It's all over the place. When we have to keep centered on the patient and define the biology. So you can see that the management of a patient coming into the long COVID clinic is you take these things and you refer them out. And then you try to say, well, what's going to happen? Well, if you send them out to a rheumatologist who's used to fatigue, they may do a pretty good job, but you send them out to someone else that thinks that fatigue is not an important symptom, that's not going to be a monitored variable. So I think we have to keep that in mind, and we need to know what's going on. So fatigue is a cardinal feature of illness itself. So this middle part of the talk is what is fatigue and what is the biology of fatigue. And there are certain things. There's TBI infection, Parkinson's disease, multiple sclerosis. A lot of these autoimmune diseases have fatigue, cancer, and interestingly, radiation therapy, which is a nice model for starting fatigue and following fatigue. And there are some people at Case that are looking at fatigue in that particular model. So there are people that have studied fatigue in animals. The subjective patient symptom of fatigue corresponds to a phylogenetically conserved and objectively quantifiable program of what's called sickness behavior. Sickness behavior includes reduced movement and feeding, social withdrawal, reduced motivated behavior, and sleep. The sick individual is viewed as being at a life or death junction, and the behavior is an all-out effort to overcome the disease. And this is in 1988. And this was after studying a variety of animals that are there. So what models have people looked at? In the preclinical models, people have mouse, rat, fruit flies, C. elegans, and cellular stress. And the therapy that they've used have been brain somatic proteins and genomics. So they've been looking at this for a while, and they have definitions of all of the various readouts of the animal: inanition, not moving, feeding behavior changes, preference for carbohydrates versus fats changes. And they think it's just a way of responding to get through the problem, and whatever that problem is. And it doesn't sit there and say, oh, my problem is, I don't know, persistence of a virus, right? Usually the virus in other models, which is in human models, it's multifactorial. It's CF, chronic fatigue syndrome, fibromyalgia, cancer therapy, radiation, cytotoxic therapy, comorbidity, performance, aircraft training is what Michael Decker looks at. There's a transient fatigue that responds to that. And the evidence-based therapy for most of this is supervised, graded, resisted exercise and nutrition plus or minus time. And those are the ones that have been there. I'm going to point out some other models that have had fatigue as an outcome, but other approaches. But there has to be time, and there also has to be, I think, nutrition and exercise. So here's one model: the sickness, whatever it is, causes cell stress. And in this particular model, epidermal growth factor was found to be an important molecule. And if you knocked it out, they didn't have this sickness response. And went to central neurons in the flatworm and the neuropeptide signaling. And it turned out it turned off certain activating neurons, and it worked on through the GABAergic system. Sleep and circadian rhythm has been looked at in the animal world, and sleep is a readout. Delta power over time is reduced, serotonergic tone, light alerting response is blunted, circadian disruption, melatonin secretion, growth, that's growth hormone, integrate energy balance. So the purpose of all this is to integrate energy balance with physiological arousal and metabolic control for survival. So you have to blunt arousal, you have to save energy, and you have to alter metabolic control. And there's one that actually has orexin right in the middle of that. So the models that people are testing is that sleep is unlikely to produce the infection in the host response. So it's one or the other. Sleep is either mitigating the infection in the host response, and that sleeping a lot is maybe protective, or that sleep is somehow equivalent to in the intermediate between the host response and death. So it could be a readout that's protective, or it could be a readout to say, oh my goodness, something is going to happen. And that's in the animal models. Now, I have another model that's like that, which kind of invokes the hypothalamus as maybe the spot in which humans and animals respond to, and it has the same sort of model. Does immune dysfunction play a role in sickness behavior? And this is the CFS model here. So sickness triggers this activated T cells. It goes to the brain, the sickness center, wherever that is, communicates sickness behavior, and the sickness behavior is all the things that we see in the post-COVID clinic, that we see in patients that walk in after with chronic fatigue syndrome, that people walk in. About 5% of people with post-rickettsial 10 months out have chronic fatigue syndrome. It seems to be a common response to a variety of triggers. Characteristics of this particular population that they looked at was that of their functioning and their average score, and they had US norms, they had controls, they had then patients, and it was about 30 to 20% males and females. Females seem to be overrepresented a bit in most of all these things. There are some theories for that. And you can see that all these things, physical function, role in their physicality and bodily pain, general health, vitality, social functioning, role, emotional, mental health. Mental health is about the same. Emotional health is about the same, but most of these other things are there. And then sometimes as a doctor, we say that's fatigue, or we say that that's aches and pains. And this is another mitochondrial membrane potential is lower in the T cells, peripheral T cells in these fatigued individuals. There's a little scatter in there, but this particular model by Daniel Peterson, I don't think it's published yet. It was presented at the sleep meetings, but this mitochondrial axis as a readout in peripheral blood is problematic from a lot of different reasons. It's not the brain, it's not the muscle, it's not whatever it is, it's not the heart. But on the other hand, it's a shorthand for saying that there's energy balance and that there's energy problems in the particular person. Decker has published unpublished preliminary data in chronic fatigue syndrome. 51% of these people showed a sleep disorder, mild to moderate OSA. So you need to make sure that these are in the wild. These were ones that he set up a sleep lab in, I think it was Kansas City, and looked at controls and looked at that were from that population and looked at the chronic fatigue syndrome. He calls those that have sleep problems the sleep phenotype, and those that have did not, they call the inflammatory phenotype, because there seemed to be a bunch of different things. I'll show you a little bit about that. They had flattened salivary cortisol over the day. So you do salivary cortisols over waking state. And then after testing, and that's interesting because you're in healthy people, your salivary cortisol goes up if you get tested for neuropsychological function. You know, it doesn't depend on which it is. It's just the stress of testing in healthy people makes your cortisol go up. But in these people, it either doesn't respond or it goes down with the chronic fatigue. And then there are other, IL-8 is one of the markers that was up in chronic fatigue syndrome, and a growth hormone like peptide was down in CFS patients. This is an example of of two separate patients. And this is delta power over a PSG. And this is a person in the inflammatory phenotype, did not have really respiratory problems. And neither of these people did, but you see the progression of high delta power at the beginning of the sleep period that diminishes as sleep progresses, which is the normal pattern. And then you see that there's in the chronic fatigue syndrome that there's a reduction in delta power. So delta power is one of the biomarkers that would be proposed in any particular study, I think. Unpublished showed graded exercise intervention. This was a pilot data in 3 CFS, the inflammatory phenotypes, and 1 that had OSA with chronic fatigue syndrome. Very difficult to distinguish between the two. Venous samples were collected at various time frames, and protocol underwent neuroimaging. And what you kind of see here is that the baseline IL-8, which was elevated, went down in the people who had chronic fatigue syndrome and underwent graded exercise, whereas it didn't change much, or maybe not change in the sleep. Now, you know, this is preliminary data, more people are needed. It would be interesting to see if you had mild sleep disordered breathing, what happened to that. But if your target is fatigue and you wanted to look at this, this could be a response. And this is an example of before on top and after. On the bottom of 12 weeks of enhanced physical activity of MRI. And what you can sort of see is that in the gyrus rectus and in the lingual gyrus, so this is shown purposely to show that there seems to be less projections there, and before, and then with after there's more projections, and that these people felt better. Now this is just an example, and it's just, you know, can you use imaging to be able to look at cortical function? This is, as you can see, an older person because they have cortical, they have diminished brain volume, but should imaging be part of this? Imaging at $800 a pop plus everything else is a readout. And then the most important thing is that people suggest in this review and what they talk about is that the peripheral inflammation can come up and affect microglial activation, or it can go up from the vagus nerve, and that those interactions then lead to our symptoms of subjective experience of fatigue, uncertainty about the usefulness of actions, that's depression, and decreased ability to switch from goal-directed to habit-like behavior, and decreased incentive or motivation. And that brain assessments in fMRI or 128 electrode array need to have some sort of task in them to try to be able to test these different parts of the brain, and that's the importance of the peripheral inflammation. And that peripheral inflammation is at 10 months or so, or several months after the acute infection, represents the activity going on in the individual that promotes an inflammatory response and produces these symptoms. So that would be the general thinking from this group of studies. So what to do about it? Well, this is another model in cancer for fatigue. I've been kind of going out. You've got predisposing and perpetuating factors. That's why it was so intriguing to find this autoimmune history to these people with fatigue. Precipitating factors, they have a cancer diagnosis and treatment, but in this instance, you can say it's a COVID infection, and that it works on these different areas of the brain, which in this particular review focused on the HPA axis and the autonomic nervous system and the pro-inflammatory cytokines. So you can see that almost anybody has thought about fatigue and any different discipline, that they can impose all their intuition on this in a variety of ways. So what's therapy? Evidence-based medicine is exercise and nutrition. Those are the ones that have the most. And the purposes of fitness and weight loss have effects on the CNS, on dopamine release, sense of well-being, self-efficacy. They get out and about in the environment, and they promote social contact when done in a supervised fashion. It seems to be supervised is better than unsupervised. And the nutritional approach is a balanced diet, whatever that means, Mediterranean maybe. And then there are these nutraceuticals of selenium, coenzyme Q, vitamins, iodine, and then kitchen sink. There's a guy, apparently I've heard, that's treating this stuff with lots of vitamin B, all the Bs you can think of, taking tons of it. And I don't know if it's time that gets people better, but some people swear by it and some physicians swear at it. So the nutrition and exercise is a nice design. This is one of the ones that showed success with fatigue. It had nutrition therapy for some period of time, and then nutrition therapy with resistive exercise. And it was a 20-week protocol. That's a long protocol. It's but 5 months. This is slow therapy, and it's a nice design. Mindfulness-based stress reduction has been also shown to improve fatigue, as well as a variety of things. And for my edification, I wanted to know what mindfulness meant. And I went down this rabbit hole and found that it means meta-awareness, present-centered awareness, non-reactivity, de-rification, which is decentering, that is, not everything is on yourself, and compassion. And there are several self-report instruments. There's some external validity to concern. I don't really know exactly what people are doing, but it certainly is mindfulness is in a popular phase right now, as it was in the 70s. But these are this was a analysis of a variety of studies that showed that depression, anxiety, and pain were reduced, that there were target symptoms, and that you have to have an active control less so maybe it's the interaction, but that generally directed courses were better than online or self-guided. And that may actually be the same for insomnia, but it's because of the number of people in insomnia that we've gone to online or self-guided. Meditation. These are the number of studies that have showed been done looking at these outcomes on stress, quality of life, etc. Just an example of this meta-analysis of this. And what you can see is vitality, physical and metabolic effects, environmental effects is a nice way of presenting it. Different color coded for effects that are positive potential, inconclusive, or no effects. And there are more studies that show positive potential or positive than there are inconclusive or mixed. So that that could be an intervention. The way forward on these syndromes requires organized research, national and regional. They have the recovery cohort. Each of the institutions has different initiatives. I'm not going to go into that, but it's an interesting approach. There are, though, going to be investigator-initiated studies, and we need to be on the lookout for each NIH institute, which will roll something out, or for private funds. It would be enhanced if we had cooperation and coordination with any of the institutional or regional efforts. That is, that we could coordinate things like questionnaires or coordinate various approaches that requires, let's say it requires compassion and mindfulness with other researchers. Because when we started off in these clinic and I wanted to put in a sleep questionnaire, everyone was saying, why burden them with a sleep questionnaire? So I think sleep is part of it. It could be certainly not a presenting major focus, but it's something that I wouldn't focus anything on sleep, but I'd focus on fatigue and make sure we weeded out sleep problems. So there are gaps. Attribution of cause has been inductive. People say, oh yeah, I've been looking at this and the same thing in this way. There's a paucity of biological measures. The priority has been we can measure it. That is, we can measure metabolic, or we can measure mitochondrial factors. So let's measure it, and it must be important, and then we can make a model. I think the plan has to verify what are the intermediate markers, like you have intermediate markers of cardiovascular disease. If you had intermediate markers for fatigue, that would be interesting. And also as important as I want to test this, it would be what would be the go or no-go decision making? Should it be measure it routinely? terms of management, we send people off to be treated by discipline and disorder-based therapies. And the control population, that's tough. I mean, for large databases, anything goes. I mean, you'll find these people probably using huge databases. And there probably is signal in there. But for focused protocols, cannot ethically offer nothing. Can we ethically offer nothing to a person? I don't know. I think we have to provide something because that's where they're coming into this clinic. Now, maybe if they weren't coming into this clinic, we wouldn't have to offer anything other than usual care. And we can follow that through. It would be that particular group, though, would have shooting stars everywhere to try to keep track of. Several negative studies in natural product therapy. Red ginseng is one, and the fatigue has shown reductions in control groups, and that's true. There may be just a time factor, so we have to be very careful about that dimension. So I have kind of put together what I think might be a protocol. It has both a strategy of collecting more information on the intake, but then trying to throw people into 3 categories: diet, resistant exercise, mindfulness, and usual care. Or there is an interesting group called best home remedies for fatigue. It's sort of like, sleep hygiene. And it has 8 therapies, and we could say, well, here are the 8 therapies, go get them. And we'll talk to you at 2 weeks intervals up to 8 weeks, and then we can measure a variety of things that might be important. So conclusions: long call clinic, 75% are fatigue, depression, insomnia, predisposing conditions, precipitating event, and perpetuating factors that are behavioral and biological, maybe an adaptive response, and as such challenges our attempt to treat it. It's interesting when you think from an evolutionary perspective that the response to the organism is a biologic response, and we want to stop that. Our approach to prevent people from who don't want to go into a raging fire is to protect them with all sorts of protective devices, and then they feel as though they can go back into the raging fire. But I think we have to kind of figure out what it is. We tend to kind of think about prednisone that way, and it may be whatever we do from a medical perspective gets people better faster rather than gets people better. So I don't know what that is. So subtypes and phenotypes are important to understand. We need a standardized assessment, outcome measures. There will be sleep phenotypes, and we can kind of try to see how well we can do that. And given definitions, phenotypic syndromes can be studied to connect the dots among the brain and the prevalent inflammatory hypotheses. So I wanted to acknowledge that David Rosenberg really kind of dragged me into this and was actually helped me put in some questionnaires about sleep, and also collected these things and supplied me with paper readouts of de-identified individuals for preliminary data to be able to kind of present the first 40 to see where we're at. And I think we have something here that's pretty interesting. And I'm sure everyone has seen sees post-COVID, and I had some input from Anna May and Rana Hedge. Rana's a big proponent of exercise and really exercise and time, graded exercise. Don't take fatigue lying down. How about that? All right, open to discussion.
Hi, this is Marvin. Dr. Strohl, first of all, Happy New Year to the group here. I think that's an interesting talk there. I have 2 questions, actually. One, I don't do critical care, but I vaguely remember there is such a thing as a post-ICU type fatigue phenomenon, just with the general ICU patients. Now, with this post-COVID physiological changes that are being proposed as to the etiology of the fatigue, do we know, are these specific to COVID somehow, or are these just from perhaps general post-inflammatory changes? That's number one. And I guess my other question is, it would be interesting that, the interleukins and the anti-inflammatory markers are being dragged into the etiology of this. I wonder if, I know there are some interleukin monoclonal antibody treatments that are being used for COVID. I wonder if we have data in terms of maybe them causing less long haul symptoms.
So on the first question, the MICU is certainly, there is an MICU effect, and it's more prevalent in MICU people, but it's also prevalent in those that are not in the MICU. And the general feeling is that some of these presentations are independent of the severity of illness. People who have mild illness who are at home can then present at 6 to 8 months with fatigue. And so that's it. And that if you look at the chronic fatigue syndrome literature, the general thinking is that why we are so disappointed with it is it's a common outcome of many viral illnesses. And many rickettsia was where it was first sort of described as an etiologic agent, and certainly not everybody with chronic fatigue has had a bout of rickettsia. But so that particular thing of what triggers it, and that's why the animal studies are interesting, is that you can use a variety of things to then trigger this response, and it seems to be perpetuated by things. Now, in terms of the inflammatory markers, and you can imagine that the literature is rife with speculation, and I'm sure in the next 3 to 4 months, we're going to have somebody treating 20 people with this and 30 people with that, and they're going to go yippee, and there's going to be a publication bias, of course. And I think maybe big data can tell you about whether these antibodies are, in fact, another vaccine has been shown to actually improve people. And that sort of says, well, is there persistence of some sort of virus or viral antigen that is in there? So I think that, everybody is scrambling. And the major point is that this is such a huge thing that there will be almost every disease you can think of could be linked to COVID-19. I mean, when you have 34 million people that have infected, you will see things that you never thought ever. Whereas on the other, so the chronic fatigue syndrome was seen in SARS by the people in Toronto when they looked at those 40 people that were infected. Moldavsky talked about, did sleep studies in 40 people, didn't find much, found that delta power change, found a little bit of insomnia versus controls, but it was there before. It's just not, this is our chance to study fatigue.
So I want to make a comment because I know a bunch of people who have long COVID, and the people cheerleading this exercise, graded exercise. It's like, we don't have evidence that it's going to help. And a lot of these people, they find that exercise makes them a lot worse. Yeah. And we really need to be careful about let's put our eggs in this basket. We don't have evidence for it yet. And we may be causing harm.
Yeah. So the chronic fatigue syndrome exercise conundrum is that if you say to Dr. Z in Kansas that exercise is important for chronic fatigue syndrome, he'll send him to an exercise physical therapist. They'll start doing things. And we all know that chronic fatigue syndrome feel worse the next day, whereas people who are normal feel worse 2 to 3 days later. And so the graded exercise, which is, you can see what that is like, under supervision with testing as to what they can do at the beginning, and trying to do that gradually over 12 weeks, is a protocol that's been replicated in chronic fatigue syndrome. So I'm not proposing that we do any exercise, that we stop thinking about exercise. I just think that the people who are out there, we just need to kind of know what is there and what our target is.
I think we need to have.
It's just as crazy to do selenium. And people are
Right, but-
doing that. Selenium.
But my point is that we may actually be causing harm, and we need to always have that up front.
Right.
That we
Well,
may actually
yeah.
be making these people worse.
Right. Well,
That's my point.
yeah. So his work with 3 people with the graded exercise showed pretty good and consistent improvement in MRI evidence. And the other work that has used graded exercise or did exercise beforehand did not find that they were deteriorating after they performed the 12-week exercise test. So,
But was
The-
this for COVID?
well, I see there's the problem is that
We
people
don't
always
know
say,
if it's
we
the
don't
same.
know with COVID, but we have precedent with other chronic fatigue syndromes. And if you look at the animal model, it doesn't matter what the inciting issue is. Now, I think there is going to be an important feature to see whether or not they still have, and you would propose one thing would be muscle biopsies. I've done muscle biopsies. I do muscle biopsies. And it's sort of like, we'll do muscle biopsies like the drunk looking under the lamppost for his keys. That's because we can do muscle biopsies. And if we find something, that's really great. But I don't know how, what the muscle biopsies will tell you, other than it'll say, okay, there's a difference. And then the question becomes why there's a difference. So that's why I'm sort of thinking that we need to have first a very good description, 360-degree description of what this fatigue is within the greater group, and then be able to go in there. And mindfulness, I think that's probably pretty good. And it's shown that it improved fatigue. And if it improved mitochondrial markers, that'd be good. And I think that there needs to be some sort of other activity. So that's my thinking about the exercise issue. Not that you shouldn't do it, but that it's interesting that chronic fatigue syndrome people who have been told graded exercise, told to exercise, say it doesn't work, and then they get into graded exercise, and it's individualized, and they go, no one told me to do it that way. So I think if you go out there and say, okay, it's exercise, walk two blocks, and you'll, that's good, because you'll say, I haven't walked 2 blocks, and they go walk 2 blocks, and the next day they're just on there. But that's not the exercise that we're talking about.
Hi, Kingman. Good morning. This is Rena.
Hey,
Thanks
Rena.
so much. Yes.
Yeah.
Good to see everyone this morning. It was a wonderful talk, and you really, as always, get us thinking about things. And I think this whole sickness, and immune response, and how sleep and fatigue intersects in the setting of post-COVID is all very fascinating. And one thing that I kind of struggle with fatigue, clinically and even research-wise, is fatigue as a symptom versus fatigue syndrome, how sleepiness intersects with fatigue, overlap between the two, independence of the two, and even clinically when we see our patients, I always try to dissect out fatigue versus sleepiness, and is one more dominant as they're both kind of going on. So measuring these things, understanding the experience of these symptoms, and then trying to contextualize this in the setting of post-COVID. Just wondering about your overall thoughts about that.
Well, I've been interested in fatigue, and I've been interested in mitochondria a long time. And this fatigue, a lot of careers have crashed on the rocks of fatigue. because it's not a fun thing to study, because everyone sort of has this idea that they know what it is. So I think if you say, I don't know what it is, and you say, but I can measure it in psychosocial domains, that is, could I put a GoPro on somebody's head for a day and see what they do, right? Could I put domains that they could report, because they're reporting things. They're reporting something cognitively. It's all in their brain. It is in their brain. It is their brain. And it is their brain that's doing that. And then somehow, to what extent is the evolutionary perspective saying that what they are doing is adaptive, right? It's not a disease. It's sort of like sunburn. The reason that we get sunburn is not to invent cortisol cream, cortisone cream. The reason we get sunburn is to say, get out of the sun, you idiot. They're burning your skin. And that's evolutionarily there. And then you develop different pigments so you don't get sunburn if you're in the sun. So, I mean, that's how that kind of happens. So all these symptoms are based upon some sort of expression of a biological report, and fatigue is probably no different.
And I think,
and so I think we need to parameterize it. And I like the 23 domain fatigue scale that was used by the CDC in trying to measure chronic fatigue syndrome in the United States when they were ordered to do so. They did everything. They did metabolomics, they did mitochondria, they did monocytes, they did everything, and they published it all. And then, because there were very prominent people had spouses and family members that had chronic fatigue syndrome and said, you're not doing anything about it. And where is that literature? It's not even, it's in 13 papers that were placed in behind journals that, I've got all 13, I read them all, but they're only in some group of people. So I think that there's, this is a defining illness to be able to be understood. And I don't think it's one, and that's what the animal stuff told me. I think it's a host response. And I think this history of autoimmune is really quite interesting.
There's a recent NIH workshop in September focused on fatigue. And I think a lot of these sort of issues you're bringing up were discussed, and even trying to identify neurobiological signatures and some traction around the biology surrounding fatigue, recognizing that there's so many different domains that are contributing.
Now, Sally and I have been talking about kids. I think the kids would give you a lot more insight, at least initially, not a lot more, but give you some insight into, because they don't have the baggage of time that the adults have, the baggage of time, the baggage of experience, the badge of exposures, the badge of whatever it is that produces all these things. That they have the substrate to get rheumatoid arthritis. They have a substrate to get hypothyroidism when they're 40 years of age. They have a substrate to get all these things. But if they do get it at that early age, then what is it that is doing it? I think that's a very promising area to look at. That's, children they say, well, children are different. Yeah, they're different, but they're not, they're still human beings, right? They still have a genetic makeup that is fatigue in children also gender related. I mean, it's overrepresented by women. And you say, well, there are lots of reasons for that, but there's lots of reasons across the world with lots of observations in fatigue syndromes. There's this guy Navarro in California who really works on mitochondria, and he thinks that mitochondrial therapy would be important. But just like Denise, I worry that if you give them something that revs up their energy, their first, it makes more ATP in their cell. Is that good or is that bad? Right? Because if it is adaptive, then it could be that that's what prevents the adaptive response. So I think, I mean, I don't want to over intellectualize it, but I think we have to get down to a pretty good, you know, and there are three approaches to this. One is the big data, right? You take, you know, 3 million people with COVID-19 and 3 million that didn't have it, and you look at what they all did, and you propensity match, and you figure out this, and you get their whatever fatigue signal you have, somebody mentions it in the chart or somebody does that, and you kind of like look at that cloud and you say those are the clouds in there, and they merge together and they all do those sorts of things. Then there's the other group that says, well, we'll kind of have, we'll see what happens if we put up our flag and say we've got this interest in fatigue, and we'll sort of see where that is. But then you always get that compared to what, and then the other is to enter people into clinical trials. And I think the idea of using mindfulness versus some somatic intervention, maybe it's passive leg lift or something like that, is it gets the idea, if I fix their muscles, do I fix their brain, or do I fix their brain, do I fix their muscles? And I think that's a good start, but that's me. Any infectious disease people around, or people other than other than what Denise knows and thinks about a lot? So that's what I'm going to present this to the COVID long haul clinic. I hope that they'll get more resources. In particular, I want to have an organized follow-up of these questionnaires. I want to know if people get better or worse when they get sent to, you know, to Connor Integrative Health and get massage and acupuncture and all that. Is that the right thing to do here, Denise? Massage, acupuncture, drain your wallet. Is that what you want to do? I mean, these guys have 5 or 6 different integrative health things, and then nutrition. You got to go, my goodness, right?
Taking people's money is a harm.
I think it is. And so I think we need to sort of figure out, we need to know, and it's going to be here for a long time. And it's really hitting people that way. You know, so I think we need to invest in having some sort of outcome, and we have to know which people come out of Connor's Health feeling better and which don't, and then figure out that the other people that don't just don't get referred. That's the 20 questions approach.
You know what scares me?
What's going on with the post-COVID? Because the problem that I have at Metro Health is that they sort of don't have a holistic view. They sort of, and I'm not sure if they have any. You've got some people that are thinking about fatigue. Tier 1 is thinking about fatigue in cancer patients, and thinking about fatigue with in his model of bariatric surgery.
You know what scares me is that we have no idea what the incidence of this post-COVID is going to with Omicron is going to be. We don't know if it's going to be less.
That's good. So do you want to have it at 10%? 10% of 30 million?
I have
Or do you want to have
no
it at
idea.
40% of 30? But it's not going to be 0. And even if it's 3%, it's going to be huge. So we got plenty of people to study, and we got plenty of people to figure it out if we want to be able to do that. So that's my argument about it. I think we need to have some big data people. We need to have just getting ability, David having ability to put up some questionnaires that people all fill out before they come into clinic was just, you know, getting him to organize that. I hadn't been able to even think of that. I hadn't been able to do that for sleep. They all go, oh, that's too much. That's too much. You know, we can't do that. Can't do that. We'll wait till we have the MR, all that, and boom, it happened within 2-3 weeks. So that's not right.